Hello, and welcome to the third episode of Med Table Talk. If you missed the first two, please check them out. I'm your host, Rashida Persinger, and I am a medical oncology nurse practitioner at the Sidney Kimmel Cancer Center in Washington, D.C., which is affiliated with the Johns Hopkins system. I'm thrilled to be joined by two expert colleagues. Tawana, please introduce yourself.
Yes, Rashida, thank you for having me again today. My name is Tawana Bradley, and I'm a nurse practitioner in Atlanta, Georgia, with Georgia Cancer Specialists, an affiliate of Northside Hospital Cancer Institute, where I practice in community oncology, where I see both malignant and benign heme, as well as all solid tumors. So thank you for having me today.
Thank you for joining us. And Blanca, please tell us a little about you.
Yes, Rashida, thank you so much for having me here today. I'm Blanca Ledesma, and I'm a nurse practitioner at UCLA Hematology Oncology in Santa Monica, and I focus on thoracic malignancies.
Thank you both. The treatment paradigm for non-small cell lung cancer shifts as new agents that target actionable mutations are approved. Our discussion today will focus on the implication of practice-changing data regarding new and novel targeted agents and the management of acquired resistance. Don't worry, you'll see these two next slides. They're only here to show you which drugs we will focus on today, and they will also be downloadable for you at a later time. As you see, we will talk about not just oral therapies that have had recent approvals, but also in the immunotherapy space as well, which should be very informative for today. Tawana and Blanca, since there is so much information as it relates to the indication and approval and efficacy and, the adverse effects and the safety, I thought maybe we could just divide and conquer and educate our audience so that they can understand a little bit better. And again, audience, don't get overwhelmed. We know that there's a lot of information here, and these next few slides will also be downloadable for you at a later time. Let's just get right into it. Recently, there was the approval of the doublet platinum and nivolumab, which is indicated in the neoadjuvant setting. There were some main efficacy points that were looked at, and the main one was the median DFS, which was 31.6 months in the treated arm versus 20.8 months in the control group. The pathologic complete response rate was 24% versus 2.2%. When we look at the adverse effects, some of the common things we see with any treatment was seen nausea, constipation, fatigue, decreased appetite, and rash. But there obviously are some safety areas that we just don't want you to overlook. Remember those immune-mediated adverse events. I always say from the top to the bottom, any organ is potentially at risk, as well as pneumonia and vomiting. Get another immunotherapy which had a recent approval indication, which was atezolizumab. This was approved in the adjuvant setting. When we looked at its major efficacy outcomes, median DFS was not reached compared with 35.3 months for the standard of care arm. And then when we look at the adverse effects, remember those common side effects we see with immunotherapy, fatigue, that decreased appetite, that nausea, that transient nausea, not the nausea that you get usually with chemotherapy, cough, and dyspnea. Safety, again, remember, it's immunotherapy. It's immune-mediated adverse events. If you don't remember anything, top to bottom, any organ. Sotorasib was approved in May of 2021. This was huge because this was the second-line indication for KRAS G12C. And why do I say that it's huge? KRAS mutation is very prevalent in this particular variant, the G12C. Its ORR was 36%, with the median DOR at 10 months. The common side effects that was seen with this particular drug, which is oral, is diarrhea, musculoskeletal pain, nausea, fatigue. Oral tyrosine kinase inhibitors, they are notorious for that hepatotoxicity. And lastly, in my category, amivantamab, and that was approved in May of 2021 for that second line EGFR exon 20. Now, I know what you're going to say. EGFR, we've heard that before. Yes, you have. You've heard that in the EGFR exon 19 and the EGFR exon 21. This is the third common EGFR, which is the EGFR exon 20. Now, this is given intravenously. It is not given oral like we're used to in the EGFR exon 19 and the EGFR exon 21. The ORR was 40%. The median DOR was 11.1 months. The median PFS was 8.3 months. And the median overall survival was 22.8 months. When we look at adverse effects, the most common ones that we see is that risk of infusion-related reactions, rash, paronychia, musculoskeletal pain, dyspnea, nausea, and those other things that we tend to see with those inhibitor drugs. What I also want to say before I pass it to my awesome colleagues is that I know some of us may not be as familiar with PFS, ORR, DOR. Please know that there's a downloadable graph which lists the definition that you can understand what these particular terminology means. Take a deep breath as we go to the next one. I'm going to ask my awesome colleague, Tawana, if you can educate us on a few more of the novel drugs.
And I'm so glad we have that downloadable resource for our nurses and colleagues to review, because I think it helps us to be able to educate our patients. We've had a lot of drug approvals, and so it's been a lot to keep up with. Mobocertinib, this was approved in the fall of 2021. You've already mentioned looking at another exon 20 drug. This is a second-line indication for those EGFR patients with exon 20 insertion. In regards to efficacy, the objective response rate was 28% with a median duration of response of 17.5 months. As we all know, most of the agents we give, they will have some toxicities. So we're comfortable managing these ILDs and pneumonitis. There can be some cardiac toxicities, particularly QT prolongation, but there can also be diarrhea. And of course, with many of our agents, we do not want our patients becoming pregnant because of the embryo fetal toxicity risk. Our next drug, famtrestuzumab deruxtecan, this is a HER2 targeted drug. And I know for many of us, we've known about HER2 targets, but mostly in breast. But now we know that there is a target now for lung. The objective response rate was 58%. With a duration of response of 8.7 months. The side effects that we're seeing was neutropenia, nausea, fatigue, vomiting, constipation, musculoskeletal pain, decreased appetite, diarrhea, respiratory infections. With all of our HER2 targeted therapies, there can be this left ventricular dysfunction. And so you want to make sure that you're getting an echo at baseline and then periodically for these patients. And then last up for me is selpercatinib. And this is indicated in adult patients with locally advanced or metastatic non-small cell lung cancer with a RET fusion rearrangement in the first or second line. And the patients who had prior treatment, their objective response rate was 61.1% versus 84.1% in those patients who were naive of any treatment. And the median duration of response was 28.6 months in those patients who had been previously treated. In regards to adverse events that were seen in more than 20% of the patients, it was edema, diarrhea, fatigue, dry mouth, hypertension, abdominal pain, constipation, rash, nausea, as well as headache. So what we need to be watching out for in hepatotoxicity, so looking at those LFTs and the bilirubin, ILD and pneumonitis can also be seen. Hypertension, again, that QT interval prolongation, hemorrhagic events, hypersensitivity, tumor lysis syndrome, as well as risk for impaired wound healing and hypothyroidism. So a lot for us to take in. We have a nice spectrum of medications that we can use for our patients. And now I pass the mic on over to Blanca to go ahead and finish us out on these new novel agents.
Thank you, Tawana. This is such an exciting time that we have all these treatment options to actionable mutations. If we're educated, then we can then empower our patients. So we're familiar with osimertinib in the metastatic setting, now know osimertinib in the adjuvant settings. One of the positive things that came out of 2020. So when we look at the median disease-free survival for the osimertinib, it was 65.8 months versus a comparator arm, and it was 28.1 months. So this is significant practice-changing data. The adverse effects is the same consistent adverse effects that have been known with osimertinib. I'm going to move on to the MET inhibitors. Capmatinib was approved in May of 2020. So another positive thing that came out of 2020 for patients that have a MET exon 14 skipping alteration. So it's a mutation that we don't see as frequently as you see others, but really speaks to the importance of doing these biomarker testing and that we do them upfront for patients. The overall response rate in the treatment naive patients was 68% versus those patients that were previously treated was 44%. Now, moving on to tepotinib, it's for patients who have a MET exon 14 skipping alteration. We're going to focus on the most recent updated data on cohort C, which is a confirmatory cohort. Their objective response rate was 60% for the treatment naive, and for the previously treated cohort was 47%. Both capmatinib and tepotinib are oral treatments. They do have a unique adverse effects that are different to other oral therapy targeted. So one of the unique adverse effects that we can see with these MET inhibitors is edema. There can be other adverse effects that we do see, like fatigue, some nausea, and then of course those other safety concerns with these MET inhibitors, such as the interstitial lung disease, the pneumonitis.
So that was some great knowledge, ladies. Thank you so much. I hope that the audience really can get at least an overview of the new novel drugs, the new indications, the efficacy, as well as the adverse effects and the safety profiles that they need to be aware of. Now I would like to switch gears. I'm so excited. We have a special guest with us today, Dr. Kashif Ali. Thank you for joining us, Dr. Ali. If you don't mind, can you just introduce yourself?
Yeah, I'm a medical oncologist and hematologist with Maryland Oncology Hematology. We've had quite a few clinical trials and have done a lot of research in lung cancer, including a lot of the molecular targeted treatments that were talked about just a while ago.
Thank you so much, Dr. Ali. I want to switch it to acquired resistance to target therapy. Can we just start from the basic, what is acquired resistance?
We know that drugs that target a mutation are going to work better than anything else out there. What you're essentially doing is you're blocking the mechanism which allows these cancers to grow. Unfortunately, what happens in most of our patients, almost all of our patients, is that at some point that mechanism is going to stop working. That drug that you are using to focus on that mutation to stop that cancer from growing will stop working. So the question then is, why is that the case? Why did you have this great target that was working so well, and all of a sudden now that target is no longer working? So it happens because these cancer cells are very smart. They figure out a way to go around that treatment. They make new mutations that then become resistant to the treatment that you're giving. Now, these mutations can happen in different places. They can happen in the original mutation itself, like a new mutation within the EGFR gene at a different location, which then prevents that drug from working because that drug was designed to work on a certain aspect of that protein or that DNA sequence. And now you've changed that. It can also happen in a way where you develop other mutations in other parts of the DNA or the proteins of that particular cancer cell. So what happens in turn is that you still may have that original mutation, but you've developed a new mutation now, which actually is even stronger than your ability to block that first mutation.
What is one of those common mutations that develop in addition to, let's just for say, EGFR mutation exon 19? When we're seeing that resistant or that acquired resistant, is there a common mutation that is seen?
Like, for example, you can develop a MET mutation or MET alteration in addition to an EGFR mutation. Also, you can also develop a C797S mutation, for example. That's another mutation that can occur in patients who originally had an EGFR mutation. So those are some examples. The question always is that why do we tell a patient initially that we're so happy you have this mutation, then we tell them later, sorry, the drug isn't working. Now, there's drugs right now that are being made that can work better than the original drug that those patients were placed on. We also have clinical trials right now that are looking at continuing the same drug that was designed to go after that original mutation, but when they develop a new mutation, combining other drugs that target the new mutation. There's so much happening right now in the lung space that I'm really hopeful for our cancer patients because, the hope always is that we can continue targeted therapy. I mean, what we don't want to do is have a patient on target therapy, then have to resort to general treatment like chemotherapy. Our goal really is to start with target therapy and then continue with target therapy. Hopefully, have target therapy that may work even better than the original therapy that patient was on.
That's a great point, Dr. Ali. Thank you for explaining that so well. You talked about new agents that are out there to kind of combat some of these resistance, as well as clinical trials. Are there agents that are approved for patients who do develop a resistance?
Yeah, definitely. So we have ormacertinib, which is a drug that is known to work when your original first generation or second generation tyrosine kinase inhibitors directed towards EGFR mutations no longer work. And the reason is because those cancers develop a new mutation, an acquired mutation called a T790M. And when they develop that mutation, olmesartanib can now target that new mutation and work. That's one example. Another example is patients who have the ALK or the ALK mutation. They are treated with a drug like alectinib or brigatinib, for example. These are your second generation ALK inhibitors, which tend to work very well. Those patients at some point can develop an acquired mutation called a G1202R mutation. And when they develop that mutation, there's another drug called lorlatinib, which can then target that mutation. So yes, so we do have drugs out there that are able to target, some of these acquired mutations that we've talked about. But we do need to do a better job because there are so many more acquired mutations that we right now do not have approved drugs for. There are still drugs in clinical trials right now, but they will eventually be approved too as they go through various stages of the trials.
I know patients are going to, they get nervous, right? They've been on this first or second line EGFR or this ALK drug that has given them, such an extended life. And I know the first thing that they usually ask, will I have the same type of response that I've had with the previous first line therapy? And then are there any additional risks and benefits with making that changes?
Your best response generally will be with the first treatment. Okay, so we know that, this is no longer the scenario where you use best for last. You want to use your best first, right? So you're trying to get your best treatment up front, and those best treatments up front can get you 18 months, 2 years, and sometimes even longer. But those subsequent treatments right now that we have available, unfortunately, do not work as long as those initial treatments do.
Thank you so much, Dr. Ali. I know the audience is probably just taking notes as you're talking. We are so appreciative of you taking time out of your busy day to join us. Thank you so much.
Welcome. Thanks for having me on here.
As we wrap up this next to last episode of Med Table Talk, let's focus for a moment on what we would like to see in a perfect world. Blanca, what would that look like to you?
Rashida, for me, in a perfect world, nurses, APPs, infusional nurses, nurse navigators would have access to all of this data, this new ever-changing treatment landscape in non-small cell lung cancer, and then they can then in turn educate and empower our patients. And as far as the resistant mutations, that we would have more potential treatments to really sequence our patients. In the perfect world, this would be it for me.
Great point. Great point. Tawana, what about you?
Blanca, you nailed it on the head. For us as APPs and oncology RNs, when we have platforms such as this, like Med Table Talk, we can get what I call a hit it and quit it, where we can log on, get the information, the most updated current guidelines, most newest update approvals. So one that we can educate ourselves so we can stay abreast of the data. So when it's time for us to go talk to our patients about safety and efficacy, one that we're helping them make the most informed decision for themselves. And then once they start these treatments, we're able to empower them to then stay on the treatment because they understand the mechanism of action of the drug, as well as the side effects, and just be able to have that open dialogue. Programs like this, I think, will really help us to help our patients, but have some promise and some light in the tunnel and help them achieve as many milestones as possible.
Both of you all make great points. I love when you say, Tawana, hit it and quit it, right? Because let's be honest, we don't have time in a busy clinic to kind of research all through it. In a perfect world, what I would see is, hey, you just click this button and they see just an overview. We're not trying to get in the weeds, but just to understand these ever-changing great things that are happening in the lung cancer field. So I agree with you all. So I'd like to take this time to thank everyone for participating in this Med Table Talk. There are several resources you can download from the activities website. Stay tuned for the final episode of Med Table Talk. We hope you learned a lot. To get credit for this activity, complete the post-test and evaluation. Thank you.